amount of interest.
Yeah.
Oh, and one thing I wanted to ask, can I say that the recording will be available or not?
Yes. Yeah, I'm just put on the recording.
Yeah, okay, that they will be able to watch it back. Yeah.
I will pause
and see where we go and how far we get. It's amazing. We've had such a response, which is very encouraging and quite frankly a little bit daunting to deal with, but never mind, we'll see how we go. We have 7 webinars in total, and today we're going to kick off with 2 webinars. The first one will be by Medtronic on sacral neuromodulation. 1 hour for each webinar. We are very tight on time, as I said. What I would like is if anyone has any objection to using their details in terms of their email address, then please let us know, because all this will be recorded and will be sent out to those who couldn't actually join now. So please, that's just a housekeeping comment which we need to do. So today we are very privileged to have 3 people from different perspectives. We have Dr. Nuno Grilo, who's from the University Hospital of Lausanne. We have Laura Thomas, who's a clinical scientist at the Bristol Urological Institute, the department lead there. And we have Patricia Smith, who's going to give her patient perspective as a patient using sacral neuromodulation. And what we will do, we will pass the hosting immediately to Dr. Grilo for your presentation, and then if you can in turn pass that on, if it doesn't work, shouldn't it work, to Laura and to Patricia, if that's okay. So without any more ado, thank you so much, and Dr. Grilo, the floor is yours. Thank you.
Thank you so much for the invitation, and thank you so much for the introduction. I'm just going to open my presentation. Okay. Are you seeing my screen?
Not yet. You are
Not yet?
closed.
Sorry, I'm just going to get out and get in again. Okay, are you seeing me? Are you seeing the screen now?
Now we do. Thank you.
Okay.
Yes, we do.
Okay, so it's in presentation mode right now. Is it okay?
Perfect.
Okay, so it's a pleasure to me today to be here talking about the role of sacral neuromodulation in the management of pelvic floor dysfunction. This is a therapy that I'm very fond of, and you'll discover soon why. So what is sacral neuromodulation? In order to talk about sacral neuromodulation, it is important to remind briefly how does the bladder and the rectum work. So The kidneys, as you know, they produce urine and send it to the bladder. And when the bladder is getting full, it will stimulate the sacral nerves. And these nerves will send messages to the brain to tell the brain that the bladder is getting full. And once we are ready to urinate, once we are ready to void our bladder, then these nerves are going to stimulate the bladder to contract, and they are going to tell our sphincters to relax so that we can empty our bladder. The digestive system works more or less the same. When the rectum is full, it is going to send a message to the brain so that the brain knows that the rectum is full. And once we are ready to void our rectum, then we are going to relax the anal sphincter, what will allow to defecate. When there are breakdowns in this communication pathway, then we can see bladder control issues or bowel control issues. In fact, the sacral nerves, they play a key role in the functioning of the bladder, the bowel, and the pelvic muscles. And the aim of the sacral neuromodulation, by using a neurostimulator and an electrode, a tined lead, we'll be able to send some mild electrical pulses to these sacral nerves. And we have observed that by sending this stimulation to the sacral nerves, we are going to be able to restore normal functioning between the brain and the pelvic organs. And so with this therapy, we are able not only to improve the sensation and the awareness of fullness of the bladder and the rectum, we'll be able to decrease the sensation of urge, and we'll be able to improve the overall control of these pelvic organs. So it might seem like a therapy that comes from the future, but in fact, this therapy is available for more than 25 years now, and it has seen many advances through the time that have helped improving the technique to decrease its invasiveness and to decrease its complexity so that we can offer it for more patients nowadays. And in fact, we know that more than 325,000 patients have been implanted worldwide for either urinary or bowel problems. How do we do this procedure? Sacral neuromodulation is a procedure that is performed in 2 stages. So firstly, there's what we call a test phase, the first stage. And this procedure is performed either under general anesthesia or local anesthesia with sedation. And what we'll do is that the patient is lying down on his belly or her belly, and we are going to introduce this electrode, this tined lead. It's an electrical wire that will pass through the skin and through the natural openings of the sacrum. The sacrum is the bone that we have in the lower part of our back, just above the coccyx and under the buttocks. So we'll stimulate either the third or the fourth sacral nerve root, and we'll connect, once we are happy with the placement of this electrode, we'll connect it to external neurostimulator. And the patient will have this external neurostimulator in a belt, an elastic belt that he or she will carry during the test phase underneath his or her clothes. So this stimulator is something like this. And as you can see here, is over the clothes just for illustration purposes, but it's something that is very discreet, and no one will notice that the patient is carrying it, even if he knows the patient has had this procedure. The patient will also receive an handheld device that is similar to a smartphone. That will be, and this handheld device will enable him to control his stimulator. So at this time, we start the test phase, and this test phase will last for 1 to 3 to 4 weeks maximum. And what we ask the patient to do is to keep track of his symptoms. So we will ask him to have a bladder diary or a bowel diary, where he's going to be as precise as he can, so that we can analyze objectively if there's an improvement or not with the therapy we are offering him. If there's at least 50% improvement of symptoms, then we'll proceed to the second phase of the therapy, which again can be performed either under general anesthesia or local anesthesia. It's a procedure that takes more or less 20 to 30 minutes. And what we'll do, if the therapy, if the phase test was a success, we'll remove the external neurostimulator and we'll connect a permanent stimulator that will be placed under the skin at the upper part of the buttock. Nowadays, patients can choose between two stimulators, either a recharge-free stimulator or a rechargeable stimulator. The recharge-free one is a little bit bigger and has an expected battery life of around 5 to 6 years. The rechargeable one has the advantage of being smaller and the advantage of having a battery life that is expected to last at least 15 years. Both systems are full MRI compatible, so patients can have full body scans with no restrictions with most MRI machines. After this stage, the second stage phase, so when the patient has the permanent stimulator, he'll receive once again what we call a smart controller that will allow him to connect to his stimulator and to adapt the stimulation as needed, or to turn it off, or to turn it to MRI mode if needed. It's quite simple to do, and the truth is many patients don't use it in a day-by-day. Don't use it every day. In fact, most of them, they just forget about it because the stimulator just works automatically. You don't have to control it all the time. You just have to control it in a few precise how do you say, not conditions, but yeah. So in the day by day, you can forget about it. You just have to use it for some surgical intervention or when you are undergoing a MRI. The rechargeable one, the patients are receiving exactly the same thing, a smart controller, but also a recharger, a charger. So this charger, the patient is going to be asked to carry it with him in a belt for around 30 minutes a week, and that will be enough to charge his neurostimulator for so that it can last 1 week more. So now that we have talked about the principle and the procedure of the sacral neuromodulation, to who can we offer this therapy? What are the clinical indications that are established? So one of the clearly established indication is overactive bladder. We say that the patient suffers from overactive bladder when he complains about urinary urgency. This is a sudden need to urinate that cannot be delayed. And this is usually associated with other symptoms like increased urinary frequency and nocturia. That means the need to urinate at night. And that can be associated with or without urge urinary incontinence. And this is the leakage of urine that is that just appears after a sudden need to urinate that cannot be postponed. Another clear indication for sacral neuromodulation is what we call non-obstructive urinary retention. So these are patients that are unable to void their bladder, and they don't have any mechanical obstruction that can explain this inability to void the bladder. So it's more like the bladder is not contracting enough or the sphincter is not relaxing enough, and this can be addressed with sacral neuromodulation. Fecal incontinence is another clear indication for sacral neuromodulation. and double incontinence, so the presence of urinary and fecal incontinence. Usually these patients are those that benefit the most from this therapy, because with one therapy, we can address both problems with great success. So what are the results for these indications? For overactive bladder, we know, as we can see here in the figure of the left, on the left, that we'll have around 86% success in that means 50% improvement of or more of the symptoms at 3 months. At 6 months, we see that it is around 80%. And at 12 months, it more or less the same thing, 85% improvement in the patients that underwent sacral neuromodulation to treat overactive bladder. On the right, you see another figure that compares the success of the therapy. So here in light blue, you see the success rate for sacral neuromodulation. And on the right, you see in dark blue, the success rate of standard medical treatment. That means physiotherapy and oral medications that can be used for the treatment of overactive bladder. And as we can see, sacral neuromodulation is clearly superior in achieving relief of symptoms than standard medical treatment. And there are some studies that allowed us to know how does it work in the long term. So as we can see here, at the beginning of the therapy, we have an 86% success rate, and this seems to last over the time. Since 5 years after the therapy, we can still see that 82% of the patients are responding to the therapy. What about non-obstructive urinary retention? Just to be clear, when we talk about urinary retention, we have to imagine that patients have to void their bladder some way. So there are mainly 2 ways these patients can void their bladder. Either they have a permanent catheter, as you can see here on the right, or they have to perform what we call self-intermittent catheterization. That means that they are going to introduce a disposable catheter several times a day, usually 5 to 6 times a day, so that they can empty their bladder. So these patients, if we don't find any mechanical obstruction that justifies this urinary retention, we can offer them sacral neuromodulation. And as we can see in this study that evaluated the efficacy of the treatment at 18 months after the stimulation, we see that 69% of the patients. Excuse me, there's someone that is talking. Can you please cut your microphone? Thank you. Yeah, so sorry. I was saying that 69% of the patients had a full improvement after the sacral neuromodulation therapy and don't need catheterization anymore. And at least 14% more will experience significant improvement with the treatment, which means that around 85% of the patients will experience significant improvement with sacral neuromodulation. Another study evaluated the decrease in post-void residual volume. And as we can see, before the therapy, patients had a mean residual volume of around 340 milliliters. And after the surgery, this decreased to 90 milliliters. And once again, at least 70% of the patients had 50% improvement or more, and 58% of the patients didn't need to perform any kind of catheterization anymore. What about fecal incontinence? Results are very good. So this is a first-line treatment of fecal incontinence. And as we can see in this study, with the group of patients that had a baseline number of incontinent episodes per 3 weeks of 30, so these patients were losing feces 30 times in 3 weeks. And we can see that after the therapy, there's a significant reduction in the number of incontinence episodes that go from 31 to 4. Also, the number of days that this patient...
Please mute yourselves. Can you please mute? Thank you.
Excuse me. Just come back. Yeah. So the number of days that these patients are presenting incontinence episodes also significantly reduces from 12 to only 3 days in 3 weeks. And this, I don't have to say it, that it has a major impact in the quality of life of the patients. So also this, also for fecal incontinence, studies show that this improvement stays in this sustained over time with long-term efficacy in 84% of the patients. And also the number, the degree of reduction of the incontinence episodes, as we can see in the short term, patients that had at least 8 incontinence episodes a week, they have now 1 episode of incontinence a week, and this is sustained in the long term. There are some not fully established indications, and these are neurologic patients and pelvic pain syndromes, like bladder pain syndrome. And there are several studies that show promising results in this group of patients with around 50% improvement. But for now, we don't have enough clinical evidence to offer it to our patients in a standard practice. What about adverse events? So the adverse events with sacral neuromodulation are almost always the same in every study. What we see is that around 10% of the patients can complain of undesirable stimulation, and this can be changed in most of the times by reprogramming the stimulator with a smart controller. Another 8 to 10% of the patients usually complain about IPG pain. That means pain in the place, in the location of the stimulator. But we hope this to decrease since the stimulators are getting smaller and smaller. So it is expected that they will cause less pain to our patients. Lead migration, that means that the electrode, so this electric wire can change from a place to another, and this can need re-intervention to place another electric wire, but as we can see, it happens in only 3% of the patients. And one of the complications that we are most afraid, but gladly happens is quite rare, it is infection. When a patient has an infection, we are obliged to explant the material. So we are never happy when it happens. Another study that evaluated adverse events at 36 months, as we can see, the longer the follow-up, of course, we also have a higher rate of adverse events. Once again, undesirable stimulation is the main adverse event, and it's quite easy to modify. IPG pain, once again, lead migration, as we can see, it's quite rare. And in this group, patients needed...
yourselves, whoever's not...
In this group, patients needed 30% surgical reintervention. And it was mainly because the battery of the neurostimulator was dead, and they need to replace the stimulator. So it's not a complication, it's an expected result of a battery that will eventually die once it has run out. So as I've said, with the smaller size of the new stimulators, we expect to have less complications of discomfort or pain with stimulator. And as I've said, most complications are easily managed and completely reversible. So in conclusion, sacral neuromodulation is a fully established treatment of overactive bladder, non-obstructive urinary retention, fecal incontinence, and double incontinence. A positive test phase is the only real predictor of success. So that's why we have to perform this intervention in 2 stages. First, we perform a test phase, and if the patient responds, then we'll implant the permanent stimulator. It is a minimal invasive, safe procedure with good tolerability and long-lasting patient satisfaction. And nowadays, it has the advantage of being full MRI compatible. And these new stimulators, the rechargeable and smaller size stimulators, are great advances that help us offer this therapy to a wider group of patients. Thank you for your attention. I'll gladly answer your questions if there are any, or I don't know if we leave the questions for the end.
I think we leave the questions for the end. Let's see how we go.
For us if that's easier.
Yeah,
but we don't automatically give pads, so we'll assess them and then they get pads if there's nothing else.
Myra, can you put yourself on mute, please?
Everyone who's not speaking, please put yourself on mute.
For 4 weeks, yeah. Yeah, that's what it says, yeah.
Myra, can you please put yourself on mute?
Okay, I think now in the interests of time, we'll move straight away to Laura. But please, everyone, put yourselves on mute. Otherwise, we'll mute you. Thank you, Laura. Sorry, just go ahead.
Okay, fantastic. Thank you for allowing me to speak second today. My name is Laura. I work at the Bristol Urological Institute, so primarily with urology patients. However, I also have a dual role within colorectal. So I have been asked to talk to you today about a couple of things. So starting off with the expectations of patients when they have their sacral neuromodulator, moving on to the education, so what you should be educating your patients on before, during, and after their procedures. Moving through to the patient follow-up, so how I look after my patients and for how long. And then finally, to try and make it not just a clinical talk, we've invited one of our patients in to answer any questions and to give a bit of a debrief on her experience with sacral nerve stimulation. So in the reality, our patients' expectations are that this is something quite magical. They're quite desperate by the time they get to us. So they've tried all conservative treatments. Dr. Grilo's been through all of the conservative treatments that we would have expected our patients to be through. And they come to us hoping for some form of miracle cure. Now, sadly, that 100% marker that they're often aiming for is not what we're also aiming for. That's not what we're looking to reach. In reality, we also look for that 50% improvement in their symptoms. And whilst that's difficult for our patients to get their heads around when their expectation is that they're going to come in and be brilliant, this is a direct quote from one of our patients that I think really kind of spells it out. So imagine you've won £10 million on the lottery, but you're as part of a syndicate. So as such, you're only offered 50% of that share of winnings. You'd be happy, right? That's what the device means to me. So that's how she feels the device has been able to help her. So no one's turning down that volume of money. The reality, however, is slightly different in that I still expect our patients to go through their bladder bowel diaries, to look at their food and fluid intake. Regardless of whether the device is in place, that's still something that's quite important. If your patient thinks that they can still get away with drinking 10 cups of tea, they're still going to have bladder symptoms. So giving them one device doesn't take away from the conservative treatment that we should still be educating our patients on. Okay, so whilst they should have failed the conservatives, they still need to be underlying in your treatment pathway. It goes hand in hand with your physiotherapy, so your pelvic floor training and the exercises that they should be doing, generally staying fit and well. Links in a little bit as well to your patients' BMIs. Okay, larger patients are much more difficult to manage with some of the newer devices we have in terms of rechargeability. And we all know that for your bladder and your bowel control, a healthier BMI is optimal. Pharmacological treatments, they should all have been through, and again, failed or have had minimal improvement on. Many of our patients will still be on some form of medication, and that's okay. Just be aware that when you're looking at your trial phase, that you want to be comparing like for like, so make sure that their trial phase and their baseline, they're on the same medications. Don't add one or take one away so that you're not comparing to comparable states. And then finally, for me, the reality is that these patients need to be committed. So they need to be committed to us and we need to be committed to them. These are long-standing interventions, and therefore the patients need to know that they can come to you at any point and that they are committed to looking after that device for the duration that they have it in. So in terms of what your patient's actually expecting, I think our role as the clinical team is to manage that, but it's also to manage it with your patient. So start by defining that goal, work out what's important for you, what's important for your patient, and how you're going to get to that. So it may be that your patient is happy to only have one incontinence episode a day. That's their goal. You know what you're trying to get to. If their expectations are unreasonable to start with, that might be something that's worth managing before you move forward. Okay. The problem is, until you know what their goal is, you don't know what you're trying to measure. So in terms of working out whether you've hit that goal, you need to measure something. Okay, so something that's a little bit more reliable. Dr. Grilo has already talked about diaries, and we use them quite religiously. So whilst you can tell if it's worked for your patient by the way they skip down the corridor during their trial, with something like this, you need a quantifiable improvement, and therefore bladder diaries, bowel diaries, symptom and quality of life questionnaires are what we would use just to track that level of improvement. Because a 50% improvement is quite arbitrary. Your patient can tell you they've improved by 50%, but it's great to see it written down. It's also really helpful when you come to review them later on in clinic. So if 6 months down the line, they're not having the same improvement that they felt they got initially, you can refer back to their early bladder diaries, bowel diaries, symptom questionnaires. Okay, so they're a good marker of how far the patient's come, and also a great way of reminding your patient where they were before. So in terms of the education, what sort of education do we give our patients, and what bits of it do I think are most important? So things to remember, the jargon, the talk that you have with your patient, make sure it's accessible. So the phrases that we use when we talk about the trial phase, for some people they are known as the percutaneous nerve evaluation. It doesn't mean anything to your patient. So make sure that the terminology that you're using, the way that you talk to your patient is all accessible for them. When you're referring to the anatomy, think about how your patient is aware of their own and what terms they use. So it's much more beneficial to have a diagram maybe, or a model for your patient to point at and describe. For the trial phase, you want to make sure, if you're not doing it under anaesthetic, you want to know where they can feel it. The same when it comes to programming. And we find that rather than trying to describe the area, being able to identify it on an image or a model is a much more reliable way and an easier way, considerably less stressful for your patient. So think about who's delivering the information as well. So depending on how your clinics are run, who's giving that patient the initial brief on what is going to happen? Is it someone who's involved in that care from the start? Because if not, it probably needs to be. They'll have lots of questions. And also the way that you describe the treatment option can be quite daunting. So being familiar with it is probably very useful. And finally, each department's different. I can't stress this enough, and I don't know what it is in other places, but within the UK, we all do something differently. So the way that we run our service here is probably very different from somewhere down the road. So making sure that the information that you're giving out is specific to your centre. We would tend to do the majority of our trial or our test phases in the outpatient setting. So they don't have anaesthetic, they are wide awake for it, which is very different from other centres. Making sure your patient is aware of that before they come, so that they're not daunted by the prospect of being awake, is hugely important. So if we're thinking about the needs to educate, this is just a kind of a quick idea about how we would educate. So what sort of tools we use to make this easier for our patients. For anyone who uses social media, it's a prime place for your patients to all meet up and discuss the care that they get in that centre and in other centres. So whilst you can't manage those forums, they are there. Expect them to be used and your name to pop up on them. But also there are some more reliable forums that you can signpost your patients to. Okay, it's nice for them to be able to have that sort of communication with other people in a similar city. Patient information leaflets, vital. For many people, they will have consent forms at the back of them to prove that they have read them. And our patient information leaflet is 20 pages long, but goes into every possible side effect, risk, and possible question. So a dedicated patient leaflet on your service be useful. Patient videos, so really accessible to those who find maybe digesting written information quite difficult. So videos are great. Medtronic, I think, have done some that you can access via YouTube, or you can have your own if that's more appropriate. On the flip side of that, we also use videos on patients' own mobile phones of the programming sessions. So for some people, using their handset becomes quite problematic. So you can do videos of that so that your patient can play them at home later on to remind themselves of how to turn the device on or off or change a program. So videos, visuals are as useful as written for some patients. We performed some hands-on equipment sessions, and that's since there has been a development in what is being offered in the world of sacral neuromodulation. So there are rechargeable and recharge-free devices, and they all have different perks, mainly perks, but there's also some things that aren't so patient-friendly about them. Being able to visualize them, touch them, ask questions has proved to be really useful prior to implantation. So everyone who goes for a full system implant, a permanent device, will have seen that device and been able to hold the handset before it becomes implanted. Not the one we're implanting, but a different one. But so that they're aware of what's going on. So they are involved in their own care from the start. Group discussions in here. So we think about doing group sessions where patients can discuss things face-to-face with us and with other people. They're not quite so common in our hospital, but I know other centres that do them, and it's a good way of relaying information. I also run a helpline, we call it. So there's a telephone number, there's also a dedicated email address. Some of my older patients, earlier ones in my history, in my clinical history, will have my personal one, but that's not ideal for everyone who's running large services. So a dedicated inbox that your patients can get hold of someone on a timely manner is important. Lots of centres won't understand what these devices are or know how to manage them. So being able to get in contact with a clinician who does is hugely important for your patient and anyone else delivering their care. So just a thought about what we should probably be educating our patients on. Dr. Grillo's talked through most of these already, but I echo those thoughts. The efficacy is important. So it's really important that you tell your patient what they are expecting. Their permanent is unlikely to be any better than their trial phase. And you know roughly the levels of expectation that you would have for your department and nationally, okay? Device maintenance. So what's going to be involved in that? If they've selected a rechargeable device, they are expected to recharge it. You know, there are things that they will need to do with their kits, with their handsets, that they will need to be advised on before. Okay. Any risk factors? So we talked a little bit before on lead migration, infection, battery positions, those sorts of things that need to be available to your patient. The information on that needs to be available before they make a decision about moving forward. The actual procedure itself. So what it involves and whether they're willing to undergo that. And then finally, the things that it limits them from doing later. very few, but professional golfer, we have one, limited his golf play, horse riding, deep sea diving. There are certain activities they won't be able to do. And unless you tell them beforehand, that can come as quite a shock for them. So just to finish off before I get Trish on, I wanted to talk through the pathway of our follow-up. Now, everywhere is slightly different, but this is how we would generally do it within our centre here. So everyone is discussed at an MDT. So a multidisciplinary team meeting where there are multiple clinicians from different sectors. They would decide on whether this is an appropriate treatment for that patient. Okay, providing that that's gone through and we're happy, then they come in for a face-to-face appointment to look at their suitability for SNS. So providing that they fit the bill for what we think is suitable and that they are willing to go ahead, we would then move them forward. Now, the sorts of things that we would be considering in that consultation are BMI. So the needle that places the temporary lead is only a certain length. You need to be able to reach the area of stimulation with the needles that you have. So maybe BMI is not the great term, but a body habitus, where your patient carries their weight, is important. Whether they're able to deal with technology. So whether they would manage a handset. We certainly have patients who find that very difficult. So whether they've got someone that could do it for them is important. And another one that we would possibly think about is whether your patient's got global pain syndromes. So whether they have a pain condition that could be flared up by us implanting. It's not a deciding factor, but it's an education factor that needs to be discussed with the patient. Once we're happy, they come in for their test phase. They then come in for a review of that test phase 2 to 3 weeks later, where they hand back in that paperwork, so your diaries and your questionnaires. And if we're happy, they go on to the full system implant, recharge or recharge free. We then see them a week after that, so that we can check their wounds, that we can switch their device on, and make sure that they have understood all the information that they've been given. We have an 8-week follow-up between their initial implant and this one, which is time for them to try the generic 4 programs generally that we have put on. And then we would see them on a 6-month or an annual basis following that. And I will see my patients annually until their battery runs out, and then we would replace it and I would see them annually again. The beauty of having an annual follow-up means that throughout that period we have an open appointment. Might not be the same everywhere, but that's certainly how we would run it here, which would allow them to come in and see us at any point. Important with these devices because if they go wrong, they can be hugely life-limiting. The points on here are just to show where we would be giving repeat paperwork. So it's really important that throughout this, to enable those measurements of efficacy, those studies that you've seen Dr. Grilo present, you would need data, you need follow-up data. It also helps your patient if you're trying to manipulate and change some of the program settings. So we've actually got Trish on the line, who is one of my long-standing patients and has very, very kindly agreed to, one, answer any questions, but also just to give you a bit of a brief on her symptoms beforehand and the impact that the devices had for her. I wonder if Trish is there. I need to unmute people. Oh, I can see Trish. She's waving. Trish, can we hear you? Have you got your mic on?
We can't hear you, Trish.
Maybe you should unmute. It's on the screen on the left bottom side.
She's not muted, but her mouth is moving and there are no noises coming out. So whilst we just see if Trish can get her noise. Oh. So Trish is in a lovely position as well, whereby Trish is actually a continence advisor herself. So had truly followed the conservative advice down to the T, and still had very bothersome overactive bladder symptoms. Can we hear you yet, Trish? I was going to put you on the main screen, but it's a bit mean given that we can only see you and not hear you. So I'm sure Trish won't mind if we can get that off me, just giving her a bit of history on her. So Trish has significant overactive bladder symptoms to the point that she had daily incontinence, had tried all conservative treatments, so all through the fluid advice, the physiotherapy, and the pharmacological treatments, with very little improvement in her symptoms. Trish has in fact returned to me, which is how she got roped into doing this, week before last, I believe, because had noticed a sudden reoccurrence of her symptoms. And on checking, her device has died. So she's managed to get almost 6 years out of her non-rechargeable device, and subsequently is having to come back in to have it replaced. But the immediate impact of that device dying has been apparent in her symptoms. Everyone's on the chat to Trish as we speak. There is a yellow triangle by the microphone and I can't free it. How do we Can we make Trish a host?
Can you hear me now?
Yes.
You can.
Now we can hear you. Go ahead, Trish. Thank you.
Oh, sorry about that. I don't know what happened. But yeah, as Laura said, I've had a device for a number of years for an overactive bladder. I tried all the sort of conventional things, changing drinking and eating habits, and taking all the different medications that were available, pelvic floor exercises, but nothing really worked for very long. And often with the anticholinergics, the side effects were intolerable. So by the time I got to the end of my tether really and heard about this and was offered this, it was like, yeah, it was a boost to me. So yeah, I went along, met Laura and had the trial, which worked very well. Like you say, it is the old device that I have. So it was really good to hear people saying that you can now have an MRI, because I was always told with my old device that, you know, make sure if you ever need an MRI, you tell them you have this device. And it's just a little bit scary in the back of your mind. So it's really good to hear that. But once I had my permanent implant, it made a massive difference. There was a lot of trial and error at the beginning to find the right setting, to just become familiar with it. I had to try a few of the different programs myself. I went back to Laura for follow-up and she changed different settings for me as well. So it was a lot of trial and error at first. I have to say, initially, I felt a little bit disappointed that it wasn't as good as I was expecting it to be. But with support and with encouragement and with trying all the different programs, we were able to find one that really did work well for me, really well for me. I would say it was life-changing. It's really, you know, because it does impact on everything. It impacts on your social life, it impacts on your work life. And I have to say, for maybe the last 5-6 years since I've had this, I haven't even thought about my bladder as a problem. You know, it's not even anywhere in my mind. It's something I've been completely able to forget about. And that's amazing. It really is lovely. But sadly, yeah, my battery has died and I'm almost back to square one again. I've had to see my GP and get some anticholinergic medications again just to tide me over. But it just reminds me of what a difference it has made. And like you say, I did my program, I was just in the drawer. I forgot all about it, really. I wasn't even aware that I had it in half the time. You do forget about it completely. In fact, sometimes I used to turn it on and turn it up just to make sure that it was still there. And then you turn it back down to the program and go, yep, still there. The only thing is sometimes because I've got the older one and it is a bit bigger, it can catch on the car door and then you remember that there's something there. But apart from that, I would, you know, I know it doesn't work really brilliantly for everybody. I know it has to be really well managed and you have to choose your patients really carefully. I mean, I would always sing its praises, but if I was ever having patients myself who were considering it, I would say it isn't for everyone. You know, it is surgery at the end of the day. It is, you know, quite debilitating initially, just adapting to it, getting used to it. And then once you've turned that corner, if it really works for you, you don't know yourself, really. And that's all I really wanted to say. But if anybody's got any questions, I'm more than happy to answer them.
Thank you, Trish. You have been the ideal patient as well. The perseverance, I think, to find a program that works sometimes takes a little while. So thank you.
Thank you very much for your feedback, and it's great to see that no matter the country, we all see the same feedback from patients. That's very grateful with this therapy, because it's, yeah, in the end of the day, for us surgeons that are used to do much more invasive surgeries, it remains a very minimal invasive procedure, and is great to see that it improves patients' quality of life so much.
It really does. I was always the person, if I went out with friends or family or anyone, I was always the one looking for the toilet. And I'm not now, everybody else is. Although I am again now, but my life is, you know, with it 1,000 times better than without. So I have no doubts that I would like to have, you know, a new battery put in and continue with this therapy, because it's worked so well for me.
You will absolutely get your new battery, but not a rechargeable. Not a rechargeable.
But then, of course, it's key to have a very well trained team that goes around all these procedure, since the doctor, the nurse, there all really has to be a team working in this kind of therapy, so that patients don't feel lonely when things are not working the right way, and they can get help, so that we can
support is vital. Even if it's just reassuring to know that that's normal.
Exactly. Yeah. And it's interesting that you confirm what I say, that most patients, they even forget when they have they have the smart controller.
Yeah, totally forget about it. It's amazing. It really is nice to have something that doesn't have any sort of adverse effects for me personally, and has such a brilliant, because after trying all the different medicines which have their downsides, and they affect you in so many other ways, you have to balance up where the benefits are, really. Whereas this, there are no downsides, not for me personally anyway. So there was nothing to weigh up.
Yeah, that's of course, when things work well for a patient, of course, for this patient, he doesn't regret at all. Unfortunately, we know that it doesn't work for all the patients. So there are some that will not see any improvement and might even have complications. In my experience, what I can say is that most of the patients that undergo a test phase and they don't respond to the therapy, they still don't regret undergoing this test phase, because at least they try to improve their health and their quality of life. And at the end of the day, they tolerate quite well this test procedure.
It was quite frustrating, I think, for you initially, Trish, though, wasn't it, to have such a good test phase? And
yes.
to not have that level of improvement moving forward.
Yeah, the test phase, because it was done while I was awake, I was able to say that it was in exactly the right place. So when I went home with the test battery, it was just remarkable. I've never known anything like it. It was like the flick of a switch, and it was really, really brilliant. So yeah, when the real implant went in, the permanent implant, and it wasn't like that flick of the switch, that was a little bit but again, with the support, with the encouragement from the team, and realizing that doesn't mean it hasn't worked, you know, we've just got to, you know, so yeah, it is a bit of an emotional roller coaster, and you're absolutely right. I think support is key.
Well, I promise we won't.
And I've had all the support I've needed, which is fantastic.
I haven't paid her to say that either.
I just want to say I've been writing furiously here, but I think what's key from what Trish is saying, and thank you so much for coming forward and giving us your feedback and your thoughts, is this flick of a switch idea, and from being an incontinent patient to being someone where you don't even have to start to think about it. I think that's magical, and I
it
think
is magical.
If we can get that across, and let's try during this week, as I say, and bring some of these therapies to the fore so that people do know about them and do know that they work. I think that that really is important. And again, the fact that there is support, that you're not alone in this, that there's a whole team of folk willing to help in whatever guise that may be. And I think if we take that take-home message from this session today, I think we've done a lot. What we will do, we will make sure that the presentations are available, if that's okay with Laura and Dr. Grilo, if you don't mind, if we have your permission to do that, then we will put that out. And as I say, the recording will be available as well. Now, if no one has anything else to say, I think we have to finish pretty smartly because we've got another webinar coming up now. Very interesting one. I hope people are going to stay for that one as well. There's another link for it. So thank you so much, everyone, and have a nice afternoon or morning wherever you are. Thank you and bye-bye.
Thank you once again. Goodbye.
Bye bye. Thanks.
Thank you.